Welcome to the Road to TiEcon 2020 Healthcare Track. I'm Dipti Desai, and I'm chairing the TiEcon Health Track and also the Thai Global Health Initiative. As you know, healthcare is undergoing a renaissance, and technology is revolutionizing healthcare through AI, blockchain, telemedicine, AR, VR, robotics, and more. Our speakers today are going to discuss how this adoption of technology in healthcare is transforming the industry. Despite the COVID pandemic and a global shutdown, the healthcare industry has been adopting tech in an exponential manner. Health tech has been fueled by tailwinds, and we look forward to our experts on this panel to educate us on where they see this going and what the post-COVID healthcare world would look like. All of our speakers today are highly accomplished individuals, and all of them have a multitude of patents to their name. I have the privilege of saying a few words about them, but their detailed bios can be found on our website. The first one is Ramesh Raskar. He is an associate professor at MIT Media Lab and heads the camera culture group there. He's also the founder and chairman of COVID Safe Paths. And today he will tell us more about this open source contact tracing app for COVID that everyone's talking about. Joining us is also Ashima Gupta, director at Google, where she's driving strategy and solutions for healthcare. She's a major influencer in the field of healthcare IT and a champion for promoting global tech innovations and infrastructure for interoperability in the various hospital systems that exist. Suraj Kapa is the director of AR/VR and innovation at the prestigious Mayo Clinic. It's highly sought after for his views on future of digital health. He routinely engages with various startups, enterprises, and academic institutions and integrates their solutions into the cutting edge of medicine. Meera Kawaha is the managing director at Deloitte and will talk about some of her work on the social determinants of health with the governors of several states, including New York and California, in their rapid response to COVID. And last but not least, John White is the chief medical officer at Webmd. Some of you may remember this company as being one of the world's earliest telemedicine, telehealth companies from the .com era. He's a physician, an avid writer, author of a couple of books, and a communicator well known in the field of healthcare and medicine. So I don't want to take up any more of this panel's time because they have some really exciting and interesting things to say. I would like to hand over to John White, our moderator and speaker for the session today. Over to you, John.
Sure, and thank you, Dipti, for that introduction, the opportunity to talk today. You know, really in terms of healthcare, that always has been a challenge to innovate, that we see some times of improvement and then we kind of scale back, or everything is in the context of cost. And really today we want to spend some time talking about what is the COVID epidemic having on innovation and what might we see post-COVID. So I want to start with Ramesh because we talked throughout COVID about contact tracing. And we know it's really, you know, basic detective work, almost like a spider web of trying to find out all the someone had. And it's very intensive and resource intensive tech. And what are you doing, Ramesh, in terms of kind of this open source to try to help folks do accurate and appropriate contact tracing?
Thank you, John. I mean, when we think about contact tracing, there are two ways to do it. One is a manual contact tracing, which, as you said, is kind of for detective work. There's a call center, there's a case management system. Thousands of people are sitting there making phone calls and supporting people who might be quarantined at home. And then there's the digital version of it, which is what we are proposing. And that involves using smartphones or other technologies to first find who's close to each other and then create a kind of a self-assessment, self-monitoring solution that will allow individuals to go through that. And you know, if people know how to buy things on Amazon, they should know how to respond to information coming about their exposures. So they're kind of these two camps about manual versus digital. And the benefit of the manual is that it's shown to be has its efficiency because of its empathy factor. At the same time, the digital solutions, of course, have the automation and have extreme privacy because you don't have to talk to any a middleman here. At the same time, it's effectiveness is not at all proven. So we are in a completely new regime today to see whether this will have an impact at all.
Now, Suraj, you're also involved with this contact tracing app as well. Is that correct?
Correct. I had the benefit of Ramesh involving me early on in their course.
And what has been your assessment of how technology and innovation is helping during this COVID pandemic?
I mean, I think not just in healthcare, but I think broadly across society, industry, and community, it's been quite clear how the evolving adoption of technologies that frankly, groups like Google and others have been adopting earlier on really are impacting us overall. And it actually relates directly to COVID safe paths when Ramesh talks about Amazon. Everything from video chat, real-time ability to intersect with other people no matter where they are effectively in real time, and to simplify the distribution of information and data through connected infrastructures, I think are being much more heavily utilized now. And in many cases, what we're realizing is the impediment to that actualization has really come not so much from technology, but from regulation. And also from a sentiment within populations of being very resistant to disruption, and whether that be because of fear of disruption based on people concerned about what else do I have to learn that's new or different that might make my job harder initially, or the question of financial incentivization of current infrastructures. Namely, if we disrupt this current infrastructure, yes, this might be a better solution, but from a fiscal perspective, it might not be as effective for my given industry. So when you think of COVID safe paths as an example, when you start adopting these integrated solutions using technology that frankly could have been really deployed during the previous pandemic back in the mid-2000s, we're really coming head to head against, hey, this might be an efficient solution that can augment what we're doing right now traditionally.
Okay. Well, Ramesh, I want to come back for a second on that to ask you to follow up. In many ways, many of these technologies could have been adopted pre-COVID. Healthcare in general is not known as early adopters of technology. Would you agree? And isn't there also an element of trust in terms of consumers, as well as healthcare industry, which they're consumers as well? Am I going to trust technology and utilize this service? How would you respond to that?
Yeah, I think this techno-utopian world and the public health world had really never collided before. And now there's a bit of an optimism that maybe technology can solve this. But you're absolutely right, John, which is that unless there's trust, we cannot make it happen. So even from MIT, we have to spin it out into an open source nonprofit, which can be audited. And of course, the code is visible to everyone. And we're developing this with our partners and with everyone. So I think privacy, consent, data silos, regulations, open source, you need all these things so that people can actually start trusting these organizations. Right. If it comes from a technology player or an existing health player that says, I'm not going to use this app, I'm not going to use this solution because, they have broken our trust way too many times now. And same thing with something coming from a government either. So I agree with you. Trust is very critical. It can be gained by our brand, which is nonprofit, and also by technology, which is showing that it's open source and privacy preserving, not by software engineering principles, but computationally private.
Suraj referenced about regulatory issues, but Ashima, I want to bring up the issue of interoperability. We've had this issue for years that, data doesn't talk to each other, so to speak, and everyone's using a different system. What are you working on in terms of addressing those issues of interoperability? Because if it doesn't work for me or my system, I'm not going to utilize it.
John, I think this is a topic I'm very passionate about and have been passionate about for many number of years. But what COVID-19 has highlighted, that interoperability is now a public health issue. Like it used to be a data sharing issue between a patient and a provider. But during COVID-19, it's clear that data and conversation around interoperability are now in public health conversations, and they are important. And the data that COVID-19, for example, you talk about lab results, the diagnosis, the symptoms, the medication a person is on, all that data today has been documented in today's EHR system. The data exists, but it's not flowing. So what we're seeing is COVID-19 is underlying the importance, not just the health data, and then I'll later talk about some of the supply chain information as well. But honing in on the health data interoperability are technologies like Cloud Healthcare API. And we work with, we're fortunate to work with Mayo Clinic and a few others where we are helping them build the technology foundation, which is built on HIPAA compliance. And it supports the interoperability of data between your mobile applications and the underlying systems, but also across the organization boundaries. And the trigger in healthcare, the CMS and ONC rules have been welcomed. I think they've been released. So I believe that would be a catalyst for now interoperability taking shape. And then COVID-19, it just puts it on the front. Like data exists, let's connect it so that we can bring the meaningful applications.
Do you think people are going to be less interested in addressing these issues if for some reason COVID moves off of the 24-hour news cycle? I mean, we've seen that before. Everyone gets excited and then, you know, there's not as much attention and people go back to their old ways, including regulators.
Yeah, I have to say the regulatory timeline came before COVID, right? They've been working on for like many years. I think there's a greater appreciation industry-wide for science and leading with science in addressing the health issues, in addressing public health issues. And data is a core central part.
Yeah.
We are all better informed in different forecasting models. I think there's never been like world's leading researchers focus on one single topic like COVID. It's inspiring to see the behind the scenes work. So we are much more aware, much more appreciative of what data can bring, what science can bring. So leading with science, leading with evidence is now mainstream conversation. When I talk to my daughters, they are talking about data models, right? So it's a way living in a very different times. And I see some of these changes will be permanent. We are altered as a society in believing that.
But payment issues have to be addressed as well. Wouldn't you agree? I mean, now we have many ways telemedicine parity, but if that doesn't continue, that's likely going to decrease consumption.
Agreed. I think what we are seeing in the industry, some of the changes are also going to be permanent. Yes, the parity for the payment is important, but that's where your value-based reimbursement models come in. Right. They have been in the works for many years. This now presents an opportunity to bring those models forward.
Okay. You know, all of this talk about innovation and technology really is about improving the care of patients, but we know that simply access to the healthcare system isn't the only predictor of good health. We know the issues of social determinants of health. We've heard more about that probably in the last 3 months than we've heard in the last 3 years. Mira, I wanted to ask you to talk about what you've been working on at Deloitte as it relates to the social determinants of health and really this 360-degree perspective of health.
John, thank you so much for that. And I am really excited about what our team has been building actually over the last 18 months. It is a population health platform called Health 360, which is based 100% on social determinants of health. And we've actually acquired 8 different commercially available data sets, which boil down to about 2,000 data elements per adult within the United States. We've then taken those 2,000 data elements and created 50 super variables, which we have then trained on 50 million clinical records. And this data set is a super
variable.
So a super variable, think about if your social determinants of health commercial data shows you've been at a grocery store, a restaurant, you've been to Trader Joe's and McDonald's, right? Then the super variable might be something around diet. Okay. Or
sounds like a super responder.
So, you know, because you can't really do real-time analytics on 2,000 elements per person, so you've got to make it something that's far more valuable. Deloitte's been using this information for more than a decade in their actuarial practice in the life insurance industry, right? To help predictively identify who might have an early death, who might have hypertension, cardiac disease, COPD, et cetera. So in February, when we knew that COVID was coming, we actually turned our population health platform, which we had been using not only for the opioid disorder, and what we do is leveraging these super variables, we can, with a high degree of sensitivity and specificity, preemptively identify who is at highest risk. So for COVID, we identified two groups of patients. The first group of patients were those by age cohort that had multiple high-risk comorbidities that could end in fatality or serious illness from COVID-19. Think hypertension, cardiac disease, et cetera, right? And the Italy data showed us that early on. So we modeled it on Italy, and then we've been incrementally fine-tuning the model as we learn more from Spain and South Korea and, you know, UK and of course the US experience. So that's the first group of patients. Those we call them your known knowns. You know these patients in certain cohorts with more than 2 comorbidities are going to be at an increased rate of mortality from COVID-19 illness. Now, your known unknowns was the second group that we identified, and those were patients who are going to be likely to fail home quarantine. Well, how do you assess that? So do they have housing insecurity? Do they have food insecurity causing them to go out a lot? Do they have transportation insecurity, or are they living in a housing situation where there is a high population density so that they cannot safely socially isolate at home, right? So if you think about 8 people living in an 800 square foot apartment, you know they're going to be at very high risk of you know, interpersonal exposure just because of the density within that household. So with the identification of these two groups of patients, we've actually been working with a number of states, helping them to identify where the next outbreaks will be, right? So again, back to your known knowns and your known unknowns. We know COVID is here to stay. We know this is going to be rolling out through the population for 2 to 3 years, right? Until we have either vaccine or herd immunity. And so each state has to be cognizant of where these patients are located so that they can appropriately provide services in those geographic areas. So for example, in the state—
3 years. Did I hear that right? You say it's going to be 2 to 3 years.
Well, you know, the data shows that the last known outbreak of the 1918 flu occurred in 1957. So
you're giving us bad news, Mira.
Yeah,
Yeah,
that would be bad.
okay.
So hopefully within the next 2 years, right? That's the hopeful, and I think the scientific consensus that we're in this for at least 24 months, but it might go longer. It's hard to know, right? But one thing we do know is that these smoldering continued outbreaks will occur within these 2 identifiable subpopulations of patients if they get exposed to this particular coronavirus. So, you know, we basically help states identify where those patients are. We can identify them down to the household level or to a zip code, you know, 5-digit zip code, a 9-digit zip code, or even down to a census tract level, however the state would like to identify the patients. And then, for example, in certain states, they are rolling out programs where they leverage fire, police, first responders, National Guard to go knocking door to door, giving patients PPE, doing testing, and then of course doing contact tracing, which is the next step, right? So identifying patients is kind of the first step, making sure they're protected and have what they need to safely home quarantine is the second step. And then the third step is to get them to testing and contact tracing. So that's what we've been working on.
Yeah. A question blah, blah. A question came in for you, Ramesh, which asks, the COVID Safe Paths app looks promising. How do you envision different contact tracing apps working with each other or within existing data sources like EHRs?
Yeah, very good question. So in fact, MIT SafePass and COVID SafePass is not here to compete, but to collaborate. And our goal is to empower everybody else, states and nations, deploy their own solutions, including large system integrators like Deloitte, right? So if they want to come and deploy something, as you said, John, the challenging part is anything that's being used by a citizen, a student, or employee, they simply won't use something that will keep track of their health, especially keep track of their social graph, right? So our goal is to empower all these players with privacy preserving open source solutions so that they can build something that's more competitive, more commercial, more for profit on top of it. And so in that sense, we are creating the framework. We think about 97% of what people need is what we have already built or we are building. And then they can take the last 2 or 3% of customization and add hooks, add data pipes, the wonderful work that Mira just described about, social determinants of health. All these things can come in together to really deploy that. So in fact, we're working with in many states and many nations already. And even in the states where other players already have contracts, we're helping them actually take it forward.
Yeah, and I wanted to talk a little bit about even the role of telemedicine. Some folks have asked about remote patient monitoring. Telemedicine simply isn't that virtual visit. It's the other elements in terms of sensors and remote patient monitoring. And really the biggest change is going to bring, how do we bring care to the patient as opposed to making the patient go somewhere to get care? But recognizing, Mira, to your point, that everyone may not benefit from telemedicine and telehealth. And in those areas of the country with poor broadband, and it still exists, is that going to exacerbate disparities? Everyone doesn't have the computer equipment that they need for the best telemedicine visit. And then, I wanted to get your thoughts, Shima, in terms of, does a technology have to save money to be adopted in this climate right now, where there's lots of cost concerns and there's limited resources? Do I have to prove that I'm going to save money?
Mm-hmm. I think so. These are very nested questions and answer like that. I've been in health IT for a long number of years. And what I saw the technology play a role here is much more of a bringing the human connection forward. So when you have this silos or the health access and equity, I think technology is now coming to the forefront in many different ways, where these patients will now have to travel multiple miles to go see a doctor. Now this meet-like experience, they can do it from the comfort of their home. So I believe it's quite the opposite. Technology is going to bridge the health access and equity. Regarding the payments and the cost, and you talked about remote monitoring as well, I want to add just a video conference one bit to the other. And when we talk about remote monitoring, there's a lot of underneath data sets, like we talk about wearable data. When Mira, you talked about social determinants of health. We're talking about your imaging in completely different system, your EHR in completely different systems. Now, all this data have to come together from a patient centricity perspective and a longitudinal system record for this visit to be meaningful. When you're coming to me as a physician or a care team member, I want to know, when was your last test? What is your current temperature? How long have you been monitoring that? And that digital infrastructure is yet to be built. In most cases, this data tsunami is coming. And maybe tsunami is the wrong choice of words in this scenario, but you see the point. There's a lot of data that will come, and we're looking into population level surveillance for remote monitoring, be it temperature readings, be it your heart rate, and how many days have you been fever free.
Oxygenation we can measure.
Yeah, across the nation, across the population, and that data wrangling is hard work, right? To collect the data meaningfully in a secure and private way and give the insights to the care team, maybe for remote monitoring, reach out to Ashrama. Her fever has been spiking for 6 days.
Yeah.
So I think pivot from telehealth to remote monitoring is an important one. And remote monitoring, for it to work in a meaningful way, a lot of data and the technologies need to come together very quickly to provide those data-driven insights to the care teams.
Yeah. I want to ask each of you about the role of funding for innovation. As you all know, it's not the government that primarily funds innovation. It's private sector. So before we can adopt innovation, we have to develop innovation. I want to ask each of you, starting with Suraj, what's the role of VC firms in developing and funding innovation? And does that have a particular perspective in terms of what they choose to fund? And is that really the best strategy when we're looking at someone's health? Suraj?
Those are good. Yeah, so those are great questions. I mean, I'm lucky in the sense of the institution I'm at and how they foster innovation internally. Mayo internally has essentially its own Mayo Clinic Ventures arm that works to facilitate almost for-profit facing deployment of technologies that are innovated from our faculty, from our students, from our residents. And, you know, we play a very large role in developing these devices. In fact, it's interesting when you look nationally at where the largest number of healthcare related patents come out of. Olmsted County, which is where Mayo Clinic is based, is amongst the top 3 along with Boston and the Bay Area. And a lot of that comes out of just internal funding and an interest from the institution in putting money towards future innovation. I mean, there's been a history of that. I mean, the G suit was in part invented at Mayo using the human centrifuge so many decades ago. So from that perspective, we're lucky, but obviously we can't get these tools and these devices and these algorithms and these technologies out in a scalable way or to the world at large without the support of for-profit industry, VCs, et cetera. And that's where, as an institution, we do work very closely with VCs that we know well, with philanthropic partners who actually wish to fund innovation and support development and deployment, or work closely with industry where they might adopt some of the technologies we develop and facilitate its deployment and commercialization. So from an academic perspective, what I see is that, you know, if we look 5-10 years ago, and you know this from, you know, your experience Webmd and everywhere else, there was kind of this period where industry had to be completely divorced from academic healthcare. And what we're realizing is that actually has been leading to an inability to innovate properly in a way that is meaningful from a healthcare system. We have a bunch of
Is it because it's just totally different mindsets in a way, how the academic community thinks versus the private sector?
It is to some extent. You know, we can think of these seemingly awesome ideas within healthcare, but they're not practical, or they can't be implemented in a scalable way. And when you have people thinking in quote unquote the ivory tower about what we could do, it's not necessarily what we're able to do in a meaningful way. And that's where you need people with the kind of on the ground strategic thinking. The other side of it is, you know, as somebody sitting in a box who has been focusing on medicine for decades, I'm sitting here thinking, all right, well, we can do this and this and this and this, but actually taking it from ideation to actualization without the engineering support, without, you know, people like Ramesh who are able to think the deeper insights to make it work from an engineering perspective, it becomes really difficult. And ideally, we have groups like Google or situations like Deloitte where you have engineers sitting next to MDs, sitting next to business people who are all conversing and thinking of all the different elements of an idea in terms of how it actually turns into an actual product that's sold.
That's a good toss to Google. Let's hear your thoughts on that.
So I think one thing I would say, I was reading some recent stat. According to American Health Association, healthcare industry providers stand to lose about $50 billion a month because of the pause in the surgeries, because of the pause in the elective surgeries and participation. And now that's the reality. So when we talk about new ideas, new innovations, we need to be empathetic to the industry. Are the solution that we are proposing, is it going to help with the operational cost reduction, cost takeout? Are we improving some physician workflows and hence saving either physician burnout time or making that patient and physician connection better? I think that lens needs to be the forefront. We're seeing furloughs across the board. So yes, the new innovation is important, but also wearing my old Kaiser hat, there's a tendency, especially sometimes we do pilot-itis, too many pilots, not many scaling. So that's a kind of disease we need to be mindful of. And more than ever, with the financial constraints on the provider systems, bringing those meaningful innovation that speak to that. So telemedicine, an example for Google Meet I think it's right now it's being offered as free. It's browser-based, right? So that's where there's no clunky system required. There's no camera. Your laptop can work. To me, that's health access and equity. Right? You have a browser connection, you can make the appointment happen. And as we increase and add more sensors, more devices, the cost factor of what that care package would look like, is it we're giving patient home 10 devices that are clunky to integrate? That's not going to work. Right? So we want to make it easy and empathetic for patients. The new era of innovations need to be helping physicians with the burnout and don't forget the operations takeout part.
We have to manage expectations on both sides, on the part of the patient as well as the part of the provider, and that where there has been some challenges in telemedicine where we've had this huge adoption, this huge acceleration, and a lot of physicians were not well prepared to do a telemedicine visit successfully. You mentioned Kaiser, they had always had a strong system in doing that, but many others did. And patients, you know, it takes a while. I still see patients. It takes a while for them to feel comfortable, you know, with telemedicine. And how do we make sure that people know when to use it? You don't use it for chest pain and, you know, dizziness and other symptoms. You need to still go to the ER. I wanted to ask Mira, though, does labeling and terms sometimes play into this when we think about innovation, adoption of innovation, social determinants of health, almost as a parlance that traditionally has been used in public health, and it doesn't sound that interesting. I'm being sarcastic. But does that play a role in terms of if people don't know what that is, then it's hard to invest in innovation? Because I don't know what SDOH is.
That is a great question, and I'm going to answer it by throwing a boatload of statistics at you.
Yeah.
So we know, for example, the United States spends more money by half minimally than any other OECD nation per capita on healthcare. We are also number 45 and falling, and we've never been in the top 10. We've never been in the top 20. We have never been in the top 30 globally in terms of healthcare outcomes. So that's one data bucket, okay? And when I first started looking at this data, all the gray hairs will show you, we were number 75 as measured by the World Health Organization. So pretty much we spend more money than everybody else, and our outcomes are very, very poor for every dollar spent. Okay, data bucket number one. Data bucket number two, if you read, you know, CBI Insights, Startup Health, any of those things that tell you the amount of money being spent on innovation on a per annum basis, and let's just take the last 5 years, we're running at about $6 to $8 billion per year in Series A, B, and C funding for startups, for niche solutions within healthcare, which have incrementally transformed healthcare and our outcomes as a nation this much. That was a zero, right? We have had zero benefit to patient outcomes. Our longevity is falling for the first time in history over the last 3 years, right? So again, this is an expense issue. We're spending money on innovation. VCs are spending money funding startups all over the place. What are we getting for our dollar? What are we actually getting for our dollar, right? So looking at those first two set of data points, you would say, man, the ROI is just not there, right? Because trillions of dollars have been spent in the last 2 decades, and we are doing worse as a nation from a healthcare burden than any other OECD nation, which is profoundly visible now with COVID-19, okay? One of the reasons we have such a massively high death rate is because we have tremendous comorbidities. We have a second peak of illness for people aged 20 to 40 because we got 20-year-olds with adult onset diabetes, hypertension, cardiac disease, you name it, right? We are far less healthy than everybody else. So you asked me about social determinants of health, right? Diet, exercise, sleep, meditation, how
I'm
much
glad you mentioned sleep. People would not have said 5 years
right?
ago.
Yeah, but so, you know, the CDC has been publishing for more than a decade that of the top 10 diseases that we die of as Americans, 8 of them are preventable with diet, exercise, and lifestyle change, which is directly correlated to social determinants of health. So what I would say to you, John, is that if we're going to spend, you know, $1 trillion investing in innovation, let's kind of back it up and really look at the root cause, just like Jaco would do. Let's do a root cause analysis to see why we are that unhealthy, right? It's not because there's, you know, it might be administrative burden, or it might be that, you know, technology is hard, but really at the end of the day, if our patients aren't healthier, then we're not hitting the mark.
Ramesh, those were some sobering statistics from Mira. So how do you view the role of VCs in terms of funding innovation? And is it skewed perhaps towards the most glitzy and, you know, the most technologically fancy devices that maybe may or may not truly impact health?
Yeah, I think Suraj hinted at it. I think I think a VC model applied to public health and digital health in general is just a wrong way to start. I think you need a sandbox, a pre-competitive environment where a lot of these things can happen, and then over time, you know, you can figure out what to invest. So the classic VC model just doesn't work to make a difference. And the points that you made about Ashima, about access, and the point that Mira made about, I mean, the social determinants of health is the most important problem to solve in most places of the world. When it comes to COVID-19, I would say majority of it is about the social determinants right now. So even for us, you know, when we were doing this work at MIT and it was just taking off, we had to make a decision. Should we do this in a for-profit way or a non-profit way? And I have done many startups, you know, I ran health innovation teams at large companies and do my own investments. But at the end of the day, we realized that this has to be done in a pre-competitive way. In fact, you know, for the listeners, I would say it doesn't make sense for anybody to go do a startup for COVID-19, because as Mira said, in the best case scenario, it's 1 to 2 years out. So what's your business plan beyond that?
I thought she said like 3 to 5.
Yeah, 3 to 5, right? But that will be more of a smolders as opposed to, you know, major fires. So I think it's difficult to convince a venture capitalist that, hey, give me $2 million or $5 million to get this started, because, you know, by the time you get going, there won't be as much commercial opportunity. So I think we have to kind of get away from a classic Silicon Valley mindset where, hey, if there's an opportunity, there must be a way we can make money. As opposed to that, I would say, let's use this opportunity for this crisis, which is also an opportunity for COVID-19, to rethink digital health, you know, public health, social determinants. How do we create a bottom-up revolution where individuals are empowered to make a difference in health? Because health is not like hurricane or earthquake where there's a disaster and you deploy a top-down solution. You know, health is a very bottom-up problem. It's about people. And if we can empower individuals, we can self-coordinate, we can self-orchestrate, and really come through it. And let's use this 1 or 2 years to create a whole ecosystem. And that's why we work with many of the partners, some of them on this call, to create that ecosystem. And out of that will come up multi-billion-dollar, trillion-dollar financial opportunities to deploy that. So let's use this 1 year to 2 years to, do a lot of pre-competitive work.
And healthcare tends to be very insular in terms of how they adopt technology, which goes to the point about interoperability. How many of these, different groups and organizations don't communicate well. And Ramesh, a question came in about many Southeastern Asian and East Asian countries have experience in making data-driven decision-making in tackling viral pandemics for 2 decades. Are we collaborating with them? Are we learning from what they're doing?
Yeah, I think there's a lot of exchange, a lot of back and forth, a lot of research that goes back and forth. But every scenario is different. Every epidemic is different. Every health challenge is different. I think in the US, the demographic is very different. I don't know, as epidemiologists, as academics, as even computer scientists like me, like to come up with models and explain how this works. But that's all based on kind of, in simple words, kind of the average case scenario. In Singapore, the challenge is because, this low wagers were living in dorms, and that's where the impact is happening. Or in the US, it's the meat factories and meat packaging industries. Computer scientists and epidemiologists don't think about this factors at all. They look at numbers, they look at R naughts, they look at the spread, and they do some simulations. And most of those things don't really apply in the real world, unfortunately. They give you an ability to say something about it, but doesn't really solve the problem. So even if you learn from another geography or another time window, it doesn't necessarily tell us what exactly we should do going forward. So it has to be very iterative and be done in the context of the population.
But what about the cultural issues relating to trusting technology, which we've talked about earlier, and adoption of technology? We saw in China that your phone could be coded based on your temperature and other variables that would allow you to enter public transportation, enter a restaurant, enter a building. Some apps in other countries, have had greater acceptance with people downloading. Just kind of go around the room in terms of how much does that matter when we're trying to innovate? That, you could say in some areas of the world, they're much more accepting of technology that is going to track you. Let's start with our friend at Google. How does that factor into, do you think, some of those cultural issues and acceptance?
Trust is the cornerstone of any new innovation going forward, because trust means adoption. Trust means people willing to participate in whatever solution that you build. And yes, there's a slightly different appetite for privacy across different countries. However, I'm yet to see someone say, in any country, you can track me for whatever reasons. I think it is important to everyone, regardless of the geography or national boundaries. In some cases, what I have seen, technologies like telehealth as an example, what we saw with our Google Meet, there was a huge uptick in the developing countries, right? There's no reimbursement models. So people were leveraging it because there was no onus on getting that integrated with telehealth workflows, writing the right CPT codes. It was need for the hour, and people embraced it much quickly than what we saw within the US, even from the telehealth perspective, because a lot of healthcare is technology, a lot of it is like political environment, reimbursements, and I see that disparity. A lot of we saw great use cases coming out in India and Latin America where it was one-off, and here we were still convincing, hey, how do we integrate? How do we, what CPT codes need to be entered? So I think all of that matters, and yes, it hinges upon trust, but there are many other factors within healthcare. It's a perfect storm of health, transparency, reimbursements, and then the technology is the underneath layer.
We have a question that came in. It doesn't say who it's for, but I'm going to toss it to Mira. That says, is COVID fear here to stay? Fear of COVID.
Fear of COVID.
How does that impact innovation?
So, fear is often an emotion that occurs because there's something that's not understood well, or something that's unknown or something where we don't understand the outcome. And I would say COVID fear in February was probably real because it was very new and we didn't know a lot. But now towards the end of June, we know a lot. We really do know a lot about how to manage COVID. We know a lot about how to protect ourselves. We know a lot about how to prevent transmission, right? And so, you know, I think that the preventive or the cure for COVID fear, as it were, is serious education at a community level, at a local level, at a group level, at a family level. And it's got to go from there, and it's got to be a grassroots all the way up, right? You know, early on, I mean, there was COVID fear going on within hospitals. There was COVID fear going on within police stations and fire departments. And, you know, largely all of that is dissipated by now. So I think as we learn more about it, the fear actually, you know, there's a lot of states who think COVID is gone. They're at the beach, they're hanging out at bars, they're partying all night long. And, you know, they just don't believe that it's here anymore at all until, of course, our next predicted wave in the fall, combined with the flu. But I think fear stems from lack of direct, clear education. And I think that with better education, with better messaging, really down at the local level, we should realistically be able to see that dissipate.
Well, I want to thank you all for sharing your insights into the adoption of technology, both during COVID as well as post-COVID. I see Dipti is back, probably telling us our time has expired for the session.
Thank you, John. I think everybody did a fantastic job. Thank you, Ramesh, Ashima, Suraj, Meera, and John, of course, for a very educational and informative session. I think attendees from near and far enjoyed and learned a lot from the session today. And, you know, you heard from Ramesh on how contact tracing is keeping us safe, and from Ashima on all that Google is doing in the world of healthcare, from Suraj and Meera for their contributions to health in a changing landscape, and from John, who did a fantastic job moderating this session and even bringing in the investors and what is the best way of investing in healthcare. And in addition to telling us about telehealth and telemedicine. So a big round of virtual applause to all of them. Really great session today.